printed off now and it's passed. We'll open it up and check the piece of paper, which there's plenty. If we had to change it, we can just pull it out and put it back in ready to go. So we're going to connect our test charge now. The lead is always connected to the AD pads in case it has to be used. We're going to arm a charge. We do have to be careful because it is live energy being used. So that's delivered. We're going to arm a second charge, but then I'll disarm it by pressing the speed dial here. So the next thing we're going to do is attach the leads to the simulator, making sure that we connect this back to the pads before we put it away. And as we change between leads, we'll now be able to see the rhythm coming up on the screen. It's normal sinus rhythm. If we want to change the QRS volume, we can just do that by selecting here, say the heart rate, putting QRS volume and turning it up. If we want to change the ECG size, we can just select that line, go down to size, and increase it. Next thing in here, over here we have the non-invasive blood pressure button, and kept in here we have the SpO2 monitor and the exit CO2 monitor, which we won't connect, but it's kept in this side pocket here. We'll also just change back to AD mode if we ever have to by pushing the button Analyze.
Connect electrodes.
Which is now back in AD mode. Right, so we have a patient here that would like to give oxygen to. Indications for giving oxygen include decreased GCS, respiratory distress or shortness of breath, shock, traumatic brain injury, smoke inhalation, saturations below 94%, and clinical judgment is a good indication for whether you think that a patient should get oxygen. Before we give oxygen, we'll check that this regulator has a Bodak seal, which it does, and then we'll firmly attach this onto the oxygen bottle. We'll then turn the bottle on and check for a good amount of oxygen and ensure that the flow rates are all working. Yeah. We'll then attach the oxygen tubing and place the mask on the patient's face, ensuring that we cover the nose and the mouth. We'll then turn the flow rate onto 6 or 8 because this is an acute mask, and so the appropriate flow rate is 6 to 8 litres per minute. Once we're done, we'll turn the flow rate off, remove the mask from the patient's face, turn off the oxygen bottle, and flush out any remaining air from the regulator. Okay, so we have a patient here that would like to give oxygen to using a bag valve mask. Before we do so, we'll check that the system has no leaks in it. So first we'll apply the filter, which prevents the patient from vomiting back into the bag. We'll then apply the reservoir bag to the top here to ensure that we can inflate it quickly, which we can, and also just check that the bag isn't leaking any air, which it doesn't appear to be. So now we'll attach the reservoir bag to the end and attach our mask to the filter end. We'll now attach the oxygen tubing to our bag and turn on our oxygen. So we'll turn the oxygen on to a flow rate of 15. For a bag valve mask, we use a flow rate of 10 to 15, but starting off 15 to ensure that the reservoir bag is inflating, which it is. Before we apply oxygen to the patient, we'll insert an OPA. First, I'll use a head tilt chin lift to open the airway, and then insert the OPA, rotating 180 degrees. We'll now apply the mask to the patient's face using a C-grip, and then ventilate the patient every 5 to 8 seconds. Checking for chest rise every time to make sure that it's effective. We're also checking for gastric inflation, and if it was necessary, we could get a second person or an offsider to apply cricot pressure if we needed it. So today I'll be demonstrating the use of suction. We have our patient here in a lateral position. First thing I'll do is test the suction unit, in which I'll kink the hose and turn on the suction unit to full volume to check that we're getting over 350 millimeters of mercury, which we are. And I'll also just test it against my hand. So we use suction when a patient has fluid in the oropharynx and they have a decreased GCS, so they can't maintain their own airway. Some complications of using suction is that it can induce vomiting, hypoxia, bradycardia, aspirations, or laryngospasm, as well as soft tissue trauma. So when we use suction, we insert into the mouth only as far as the eye can see, and then on the way out, we use a rotating movement and cover this hole to complete the suction, and we only suction on the way out, and only for up to 10 seconds at a time. If we were to not be getting 350 millimeters of mercury, then there could be something wrong with the connection through the hosing, so we would just test to make sure that there's no leaks. We would also never use a rigid catheter in a moving vehicle. So today I'll be demonstrating the use of some airway controls, starting with an OPA. So before we insert it, we'll use a head tilt chin lift to open up the patient's airway. This is the oropharyngeal airway, and we use this with patients with a GCS of lower than 8, specifically a verbal response less than 2, and so they're unable to maintain their own airway. Some contraindications of the OPA is if the patient still has an intact gag reflex, or there's any other obstruction that would make the use of it inappropriate, such as lockjaw. Some complications of the OPA is if the size is too big or too small, it can do damage to the oropharynx, it can induce vomiting, or can further block the patient's airway if there's already an obstruction there. So we measure the OPA from the corner of the mouth to the angle of the mandible, as such. To insert it, we insert into the patient's mouth, avoiding the tongue, and then rotate 180 degrees into the mouth, and then just check the patient has taken the OPA well, which this patient has. Next, I'll be using an NPA, which is a nasopharyngeal airway. Again, this is indicated for a patient with a GCS less than 8 and a verbal response less than 2. Usually, if an OPA is inappropriate, this is used. The benefits of using the NPA over the OPA is that there's less chance of inducing the gag reflex, and it can be used on patients with a higher GCS. Some contraindications for the NPA is if there's a severe head injury in case of base of skull fracture. Some complications include bleeding or nasal polyps. So to measure the NPA, we measure from the corner of the mouth to, from the nostril, to the earlobe, like this. Before we insert it, we lubricate it with a water-based lubricant, like this. But today we'll be using a mannequin-approved lubricant. So to insert, we choose the biggest nostril, and if we meet any resistance as we insert it, we can overcome this by rotating the NPA, or if there's too much resistance, we can try the other nostril. And again, just checking that the patient has tolerated the airway after we've inserted it. patient here that has a bleed to the forearm and we're going to treat that. The first thing I would do is use this saline irrigation to clean the wound. However, that's not necessary for this patient, so we won't do that. Another option I have is I could pack the wound with dressings if it was needed, but again, that's also not necessary here. So what I'm going to do is use the smallest dressing possible to cover the entire wound like this, and then use a bandage to apply pressure and hold that onto the bleed. So we're going to apply this bandage nice and firmly, but not so tight as to cut off all circulation to the patient's arm. Another option you have is to twist the bandage over the bleed site to apply extra pressure. So I'm with a patient complaining of leg pain, and before I assess what's causing that leg pain, I'm just going to get his consent to do so. So is it right if I expose both of your legs and give them an assessment to figure out what's causing you your leg pain today?
Yep, that's fine.
Okay, so I'm going to expose both legs, and then I'll be using the PLUSTIS acronym to figure out the likelihood of a fracture in his right leg where the injury is. So on a scale of 0 to 10, with 0 being no pain and 10 being the worst pain you've ever felt, what would you say the pain in your leg is?
About an 8.
Okay, so that's pretty severe pain. I'm now just going to be checking for any deformities, swelling, or unnatural movement in the leg. I'm also going to be comparing both legs and to check the neurological and cardiovascular integrity. So that's capillary refill in his toes, which is coming back fine. Pulse in his leg, which is both have the same strength and regularity. The temperature of both legs is approximately the same. So if you just move your toes for me.
Yep.
Great, thank you. So I'm querying a tib-fib fracture in his leg, and so I will splint that with a box splint, but before I do so, I'm going to give him some analgesic pain relief to ease his pain. So what I'm going to be using today is methoxyfluorine, which is indicated for moderate to severe pain, which with a pain scale of 8 is indicated on this patient. I'm just going to be going through some contraindications to make sure this medication is okay to use with this patient. So sir, do you have any history of malignant hypothermia in your family?
No.
Do you have any known renal impairment?
No.
Have you had methoxyfluorine in the past week?
No.
Do you have any known allergies to any medication?
No.
And because he can answer my questions, he's obeying commands. So first, before I administer it, I'm just going to do a drug check on the methoxyfluorine, which is methoxyfluorine 3 mils, expiring 2017.
Methoxyfluorine 3 mils 2017.
So I'll be administering the methoxyfluorine through the green whistle and using a mask to prevent any secondary inhalation from myself or my offsider. I'll be using 3 mils. In a patient over 12 years old, I can give 6 mils, but I'll be starting with 3. So I'm just going to pour this into the whistle. Now, so I'm just going to give this to you. You can inhale it yourself. Before I give it to you, I'll just tell you there can be some side effects when you take this, and they include drowsiness, euphoria, or you may feel a bit nauseous. So I'm going to give this to you. I'll put it around your wrist, and you can inhale it yourself. I'll just put the mask on your face like this. It should take 2 to 3 minutes, no more than 2 to 3 minutes to take action. And if you start to feel uncomfortable, you're in control. So you can take the mask off your face, and it should start to wear off in another 2 to 3 minutes. Okay. So now that the patient has had some time to take pain relief, I'll just check that the pain relief is working. So on a scale of 0 to 10 again, what would you say your pain is now?
About a 3 or 4.
Excellent. So now that the pain relief is working, we're going to use a splint. So with this box splint, my offsider is just going to lift the patient's leg up above and below the injury, and the purpose of using the splint is to immobilize above and below the injury. Okay. Okay, so what I've done is use 2 towels to support the leg in the splint, and then I've used triangular bandages to tie the splint off. One is firmly around the ankle and under the foot, which is below the injury. One is firmly above the injury, and then the last tie is around above the injury site, but it's not tied as tightly, so as not to cause the patient any more pain. Now that the splint is on, I'm just going to recheck his cardiovascular and neurological integrity. So the cap refill, which is coming back fine, the pulse, which is coming back regular and same strength. So if you will be your toes to me again.
Yep.
Great, and they're still about the same temperature also.